the concept of SLAC is not new, because it's a sort of stromal keratophakia that was proposed by Professor Barraquer at the early 60s. But the new thing is the laser. The first stromal lenticle addition keratoplasty using femto was proposed by Professor Mastropasqua in Chieti by inserting a negative meniscus shape lenticle that is thinner in the center and thicker in the periphery in order to obtain a sort of intrastromal ring effect by flattening the cornea. But despite the good integration of the lenticle, the functional outcome was not very good. So our group wanted to investigate the outcome of a positive meniscus-shaped stromal lenticle in order to fill the gap of the ectasia to obtain a thickening and a regularization of the cornea. So at the beginning, we start with an ex vivo model by creating a sort of ectatic model using excimer in the posterior face of a cornea. Then we cut the lenticle, we create the pocket, and we insert the lenticle into the pocket by using the femto. This is briefly the technique. We mounted the ectatic cornea in anterior chamber, artificial anterior chamber, and we try to put the lenticle inside the ectatic area. Now you can see up the ectatic profile obtained by excimer, and above the same cornea after the implantation of the lenticle in the stromal pockets. What we notice obviously an increase in corneal thickness, but a reduction in maximal posterior elevation and a significant flattening in K reading of the posterior surface of the cornea. And you know that keratoconus is mainly a posterior disease of the cornea. So we pass through the clinical practice, and we enrolled 16 patients waiting for DALK with advanced keratoconus, intolerance to the contact lenses, and we scan at pre-op 3, 6, 12 months of follow-up. We try to customize the lenticle for each patient, and we decide the diameters of the lenticle based on the ectatic area on the tomography, and we calculate the thickness of the lenticle in order to obtain a total corneal thickness of 600 micron. The pocket was created very deep, 100 above the endothelium. So the surgical technique is very easy. First of all, we create the lenticle. Then we mark the center of the lenticle because we're positioning the lenticle in the ectatic area. So this is the center. Then we pass to the patients. At the same time, we mark the center of the ectasia, not the center of the cornea. This case is a quite central keratoconus. We open the pocket easily, and then we insert the lenticle in the pocket using a Burato forceps. We put the lenticle inside, then we try to center in the ectatic area and try to leave the lenticle without any folds, obviously. The procedure is made by topical anesthesia, and at the end of the procedure we put a contact lens, and that is all. This is the result. You can see the perfect integration and the perfect transparency of the cornea through the follow-up. This is the pachymetry map, on which obviously we notice a corneal thickening, but also we have a much improvement in much of index of aberrometry, and all the patients report a contact lens wearing tolerance recovery, obviously with a significant improvement in visual acuity. At the same time, in vivo confocal microscopy confirmed the perfect integration of the lenticle with the respect of the other corneal structures, with a reduction in time in the reflectivity of the anterior and posterior surface. We studied the biomechanical property of the new cornea, and also in a thickening effect, we noticed that a strong stiffening effect of this cornea by using the Corvin machine. But, however, the anterior K-index remains high, and the visual acuity with the spectacle is not very good. So, at the moment, we are treating with a customized PTK some of these patients, and we reach a mean improvement of spectacle correction visual acuity of 3 lines, a reduction in anterior keratometry, no statistical reduction in the pachymetry because we want to fix only the aberration and not the refractive error, and a further improvement of the profile of the cornea. Of course, after excimer, the cornea is a little thinner and softer, but if we compare this result from the baseline prior to the lenticle introductions, we maintain a very strong and thickened cornea. So for this moment, we believe that it could be a starting way to treat some keratoconus patient by an adding therapy instead of a substitute therapy. Thank you very much.
Perfect. Thank you, Emilio. So there were 3 tissue-edit methods for keratoconus surgery mentioned at this ACOS webinar. There was a lenticle obtained from hyperopic smile, which is biconcave, which was placed symmetrically, centrally. That's number 1. Number 2, that's your method, where you take a lenticle, which is biconvex, obtained from myopic smile, and you place it eccentrically on the apex where the cornea is the thinnest and weakest, and you place it really deep. And then the third method is corneal allogenic ring, which is kind of bridging the apex, trying to make the cornea stronger and more regular. So it seems, Emilio, like you are more focused on the posterior aspect of keratoconus. Is that correct?
Yes, that's correct, because keratoconus starts from the posterior part of the cornea, and if you move to the bulk, if you perform a very deep bulk, the result is very good. But if you leave some amount of stroma, you maintain the tactic shape of the posterior cornea, and the visual acuity is going worst. So I think it's most difficult to regularize the posterior part of the cornea with adding the tissue. So we prefer to put the lenticle very deep in order to regularize the posterior part of the cornea, because the anterior part is more easily, for example, with the excimer. And if we want to obtain intracorneal ring effect, you should use a very large lenticle. In our cases, we perform a smaller lenticle introduction. We only pay attention if the age of the lenticle fall in the optical zone. We maintain the lenticle a little bit larger to avoid the edge of the lenticle in the optical zone.
Yeah, excellent. So, Supi, which of the 3 mentioned methods do you think is going to be the most successful?
Well, difficult to tell. And the keranatural tissue is possibly cross-linked, and you could do that as well. And then nomogram refinement will even be more complicated, because depth of tissue implantation plays a role, the convexity plays a role, and then you could titrate by cross-linking the stiffness of the material. If you cross-link it outside of the cornea, you can make it really strong. And if you put it inside and cross-link in one session, that would be another method. So there is a lot of development still to do, and a lot of more conferences are needed for that. Thank you, Emilio, for this brilliant work.
Thank you, Susi.
Excellent. Yeah, very nice, very interesting. From my point of view, the corneal allogenic rings hold the promise of being the least invasive for the three mentioned method. We don't cut through the center of that weak cornea, but we will see. We need to, collect the clinical data with the longer follow-up at this disease. But it's again great that we have more ways to go forward with keratoconus, which is a really challenging disease.
Yes.
Thank you so much. Thank you so much for participating at this ACOS webinar, which was focused on lenticle extraction and the derived new methods. Your contributions were really excellent, and we are going to hear more about these new surgeries in the future. And thank you for opening these new doors to all of us.
Thank you so much, Pavel.
Thank you for the invitation.
Bye. Thank you.
Thank you. Bye. Have a
Bye-bye.
nice meeting. Bye.